Hi, good evening, everyone. So today I want to walk you through the anesthetic consideration for anterior cervical discectomy and fusion ACDF, a common yet critical neurosurgical procedure where surgeon is focused on decompressing the spinal cord and stabilizing the cervical spine. Our job as anesthetists is just as vital. Now, we must ensure that airway management, hemodynamic stability, neuromonitoring adjustment, and smooth emergence is happening. All the while, we're keeping the patient comfortable and safe. Now, so what are the preoperative considerations? Now, before the patient even enters the operating room, we need to assess their cervical range of motion. Many of these patients have limited neck mobility due to pain or stenosis. This means we must prepare for a challenging airway. So, having a well thought out airway plan is essential. What all should we have at the bedside? Glide scope, maybe even fiber optic equipment if the airway is really challenging, Mac or Miller blades, a flexible bougie, suction ready to go, and so on. Now, if range of motion is severely restricted, an elective glide scope intubation in neutral position is often the safest approach. Documentation is key. Always note that intubation was performed with the head in neutral alignment. Now, this is written in detail in order to avoid liability issues later on. Okay, so induction and airway management. Now, this is no doubt a general anesthesia with an endotracheal tube intubation case with rare use of NIMS ET2 unless specifically requested by the surgeon, okay, for monitoring of the recurrent laryngeal nerve function. Now, if the surgeon enters from the right side, we may need to tape it to the left side of the mouth to keep it out of the field. Now, a flexible tube extender can also help keep the anesthesia circuit out of the way of surgeon's field, and this is how I prefer doing it. Now, what about the hemodynamic considerations? One of the biggest concerns during ACDF procedures is maintaining a stable blood pressure. Why? Because many of these patients are prone to hypotension due to pre-existing spinal pathology, inhaled anesthetic effects, and positioning. So before the arms are tucked, ensure the IV is running well. A 20 gauge IV is usually sufficient. I prefer 2 just because the arms are tucked and I don't have access in the middle of the procedure. And it also is based on patient's medical history. You may consider using stopcock or a multi-port connector if you're running multiple drips. Now, if muscle relaxant is not permitted during the case, we will need to use a higher MAC to prevent patient movement. This increases vasodilation, making use of a different drip essential. Okay, so a small boluses of propofol or ketamine just before incision can also help with analgesia and prevent the movement. Now, I run personally these cases with propofol and remifentanil drips as neurophysiologic monitoring is done in my facility. Now, while neuromonitoring is not common for ACDF, it may be requested in cases of severe stenosis or depends on the surgeon's preference. Now, if intraoperative motor and sensory monitoring, NEPs or SSCPs, are used, our anesthetic plan will shift to a complete intravenous technique. Now, inhalational anesthetic is reduced to about 0.5 MAC or none given. A propofol infusion about 100 mics per kilo per minute is initiated. Small doses of short-acting narcotic drip may be added. However, any adjunct based on anesthetist's preference can be added to deepen the anesthesia and prevent movement. I personally use propofol and remifentanil and it works just as well. Neuromuscular blockade is avoided or minimized just for the case of intubation. So this also means we must coordinate closely with the neuromonitor tech, ensuring that twitches have returned before monitoring begins to its baseline. Now, if relaxation persists too long, we may need to reverse the paralytic while keeping the patient under general anesthesia. All right, so let's talk about intraoperative considerations. The surgery itself is typically about 1 to 2 hours with minimal blood loss. However, complications can arise, and this could include carotid or vertebral artery damage, resulting in stroke risk, recurrent laryngeal nerve damage, resulting in hoarseness, esophageal or tracheal injury, infection risk, spinal cord injury. Neurological deficits can occur because of that, and then hematoma formation. And this could result in airway obstruction risk postoperative. Okay. Now, what about emergence and extubation? Now, emergence in ACDF cases must be smooth, controlled, and without coughing, as excessive movement can disrupt the fusion hardware or increase bleeding risk. Now, strategies for non-coughing emergence can include lidocaine, like 0.25 milligrams per kilo IV before extubation, Precedex boluses, propofol boluses, even use of narcotics. So it depends on what you get comfortable. You can tweak as you go on. I personally, love to wake them up on remifentanil drips. Now, the goal is to prevent strain on the surgical site while ensuring a patent airway. Okay, so postoperative considerations, what are they? Monitor for hematoma formation, as it can rapidly obstruct the airway, right? Assess voice changes due to recurrent laryngeal nerve injury, and continue blood pressure management to prevent excessive fluctuations that might compromise the fusion site. Okay, so now as anesthesia providers, our role in ACDF extends far beyond just putting the patient to sleep and waking them up. We are responsible for airway safety, hemodynamic stability, pain management, and smooth emergence, all the while adapting to unique surgical needs of each case. Now, collaboration with surgical team, careful preoperative assessment, and proactive intraoperative management are key to ensuring a safe and successful outcome for the patient. Thank you, and good luck with your surgery.